You went to bed at a reasonable hour, you got 7 hours of sleep, maybe 8. You did not toss and turn dramatically. You did not lie awake for long stretches staring at the ceiling. By every surface measurement, you slept. And yet, you woke up this morning the same way you have been waking up for months, possibly for years, exhausted, not the normal grogginess that clears in 20 minutes with coffee and daylight, a deeper, more pervasive exhaustion that does not lift the way it used to. A fatigue that is present before the day has asked anything of you. That has you already calculating when you might be able to rest again before you have finished your first cup of coffee. That you have mentioned to your physician, possibly more than once, and that has been met with some version of the same response. At your age, sleep quality changes. It is normal to feel more tired. Try going to bed earlier. Make sure you are getting enough sleep. You are getting enough sleep. The problem is not the sleep, and the fact that no one has told you what the problem actually is. The specific physiological reason that a majority of adults over 60 who wake exhausted despite adequate sleep hours are waking exhausted is the gap this video exists to close. Because the reason is specific, it is mechanistically understood, it has a diagnostic pathway, and it has a set of interventions, several of them with strong clinical trial evidence, that most people dealing with this problem have never been offered because their physician has never gotten past the assumption that fatigue in an older adult is simply what aging looks like from the inside. I am going to walk you through the 4 most common physiological causes of non-restorative sleep in adults over 60. Sleep that is long enough in hours but not sufficient in quality to produce the restoration the body requires. I am going to explain the mechanism of each one. I am going to give you the specific tests to ask your physician for by name. And I am going to give you the specific interventions, dietary, supplemental, behavioral, and where appropriate pharmacological, that the research supports for each cause. Because the exhaustion you are waking to every morning is not aging, it is a set of biological processes that have gone unaddressed. And biological processes, unlike aging itself, can be addressed. My name is Dr. Alan Westbrook. I have practiced internal medicine with a subspecialty in sleep medicine and fatigue in older adults for 22 years. The single clinical observation that most fundamentally shaped how I approach morning fatigue in adults over 60 is this. The majority of patients who come to me with the complaint of waking exhausted, despite what they report as adequate sleep hours, have at least one identifiable, treatable physiological cause for their non-restorative sleep pattern. And in approximately 60% of cases, that cause has never been specifically investigated. It has been attributed to aging. It has been attributed to depression. It has been attributed to medications as a side effect that must simply be tolerated. And it has been left in place for months and years while the patient adapts their life around a fatigue that was always addressable. That is what I am going to help you change today. Before I go further, I want to hear from you. Drop where you are watching from in the comments right now. And if you regularly wake feeling unrefreshed, tired after what should have been enough sleep, type yes in the comments. I want to know how many people watching this are in the pattern I am about to describe. Let me start with the distinction that frames everything I'm about to say, because it is the distinction that most clinical appointments never make. The difference between sleep duration and sleep architecture. Sleep duration is the number of hours between lying down and waking up. Sleep architecture is the internal structure of those hours, the sequence and proportion of the different sleep stages that occur within them, each of which serves distinct physiological functions that cannot be substituted by simply adding more hours. When physicians and patients focus on sleep duration, and when duration appears adequate, the conversation ends. When the focus shifts to sleep architecture, what is often revealed is that the hours are present, but the biology happening within them is not. And that distinction is the entire explanation for waking exhausted after sufficient sleep. Sleep architecture in a healthy adult consists of cycles that repeat approximately every 90 minutes across the night, each cycle containing a progression from light non-REM sleep through the critical slow-wave deep sleep stage and into REM sleep. Slow-wave sleep, also called stage N3 or deep sleep, is where the glymphatic clearance of metabolic waste from the brain occurs, where the most significant growth hormone release happens, where immune consolidation and tissue repair are most active, where cardiac recovery from the day's sympathetic demands is concentrated. REM sleep is where emotional processing, memory consolidation, and the integration of the day's learning occur. These are not optional stages whose functions can be performed in other stages. They are biologically specific windows, and when they are compressed, fragmented, or suppressed by any of the causes I am about to describe, the body does not get the restoration they are designed to provide, regardless of how many hours pass on the clock. You wake exhausted not because you slept too little, but because the sleep you got did not contain enough of the biology that makes sleep restorative. The first cause is subclinical or undiagnosed obstructive sleep apnea, and I lead with this one because it is simultaneously the most common, the most underdiagnosed, and the most treatable cause of non-restorative sleep in adults over 60. Obstructive sleep apnea, the partial or complete collapse of the upper airway during sleep that causes repeated cessation of breathing, affects an estimated 30 to 40% of adults over 65 in the United States by current epidemiological estimates, a prevalence that makes it roughly as common as hypertension in this age group. Yet the majority of those adults have never been formally diagnosed. The diagnostic gap exists for a specific reason that most people are not aware of. The classic presentation of sleep apnea, the loud, disruptive snoring that wakes a bed partner, the witnessed apnea episodes, the gasping for air, is less universally present in older adults than in younger ones. In adults over 65, sleep apnea frequently presents atypically, with less dramatic snoring, with fewer witnessed apneas, with the primary complaint being daytime fatigue and morning exhaustion rather than the nighttime symptoms that most sleep apnea awareness efforts have publicized. A study published in Chest Journal found that adults over 65 with polysomnography confirmed moderate to severe sleep apnea were significantly less likely than younger adults to report typical nighttime symptoms, loud snoring, witnessed apneas, gasping, and were significantly more likely to present primarily with fatigue, morning headache, and cognitive complaints. They did not look like sleep apnea patients. They looked like tired old people, and they were being treated as tired old people rather than as sleep apnea patients for years, while the repeated oxygen desaturations of apneic events damaged their cardiovascular endothelium, disrupted their slow-wave sleep, and produced the non-restorative sleep pattern that brought them to physicians who could not identify the cause. A meta-analysis published in the European Respiratory Journal found that every apnea event produces a microarousal, a brief ascent to lighter sleep that does not reach full wakefulness, but that interrupts the continuity of slow-wave and REM sleep, along with an oxygen desaturation that activates the sympathetic nervous system and produces a transient blood pressure and heart rate surge. In an adult with moderate to severe sleep apnea, experiencing 20 to 30 apneas per hour of sleep, the architecture of slow-wave and REM sleep is catastrophically fragmented across the night. 7 hours of sleep with 25 apneas per hour is not 7 hours of restorative sleep. It is a physiological simulation of interrupted sleep from which the person wakes depleted rather than restored. The specific request for your physician: if you wake exhausted consistently despite adequate sleep hours, ask specifically for a referral for a sleep study, either an in-laboratory polysomnography or a home sleep apnea test, which is a validated alternative for most adults without significant complicating conditions. Do not accept a general response to get more sleep. Ask for the study by name. A study published in JAMA found that treatment of sleep apnea in older adults with CPAP, continuous positive airway pressure, the primary treatment for obstructive sleep apnea, produced significant improvements in daytime sleepiness, quality of life, and cognitive performance, with benefits that were maintained at 12-month follow-up and that were most pronounced in adults who used CPAP for 6 or more hours per night. If CPAP has been recommended to you in the past and you discontinued it because of discomfort or inconvenience, the technology has advanced significantly in the last 5 years. The ResMed AirSense 11, the current generation device from the most clinically studied CPAP manufacturer, incorporates auto-ramp technology that gradually increases pressure during sleep onset and a humidification system that reduces the mouth dryness that was the primary complaint driving CPAP non-adherence in older adults, available through sleep medicine providers and through direct insurance channels, with most Medicare plans covering the device with appropriate documentation of diagnosis. The most common barrier to CPAP use, the mask, is addressable through the wide range of modern mask options, and most sleep medicine practitioners now offer mask-fitting trials before committing a patient to a specific interface. The obstacle that most people attribute to CPAP is solvable. The continued exhaustion from untreated sleep apnea is not a small quality of life inconvenience. It is a daily cardiovascular, cognitive, and metabolic burden that accumulates over years. The second cause is thyroid dysfunction, specifically hypothyroidism, the insufficient production of thyroid hormone, which is among the most common hormonal conditions in adults over 60 and among the most commonly missed in standard laboratory evaluation. The thyroid gland produces hormones, primarily thyroxine, or T4, and triiodothyronine, or T3, that regulate the metabolic rate of every cell in the body. When thyroid hormone production is inadequate, cellular metabolism slows. Every biological process that depends on adequate cellular energy production runs below its optimal capacity. And the overlap between hypothyroid symptoms and the general description of age-related fatigue is precise enough that hypothyroidism is routinely missed in older adults because its presentation is attributed to the aging process rather than to an endocrine dysfunction that is straightforwardly treatable. The specific thyroid symptom constellation that the research documents as most common in adults over 60 with hypothyroidism is distinct from the textbook presentation in younger adults. Younger adults with hypothyroidism typically present with weight gain, cold intolerance, dry skin, constipation, and depression alongside fatigue. Adults over 65 frequently present with a more attenuated picture, primarily fatigue and cognitive slowing, sometimes with mild constipation and mild cold sensitivity, often without the dramatic weight gain that makes younger hypothyroid patients more recognizable. A study published in the New England Journal of Medicine found that in a cohort of adults over 65 with newly diagnosed hypothyroidism, the majority had been symptomatic for an average of 2.5 years before diagnosis, with symptoms attributed to aging, to depression, and to the general slowdown of advancing years rather than to a measurable hormonal deficiency. The diagnostic nuance that most patients need to understand: the standard thyroid test ordered in most primary care settings is TSH alone, thyroid-stimulating hormone, which reflects the pituitary gland's signaling to the thyroid. An elevated TSH indicates that the pituitary is working overtime to stimulate a sluggish thyroid, which is the laboratory signature of hypothyroidism. This test is appropriate and the primary screening tool. However, TSH alone does not capture two categories of thyroid pathology that the research increasingly identifies as clinically significant causes of fatigue and non-restorative sleep in older adults. The first is conversion dysfunction. When the thyroid produces adequate T4, but the conversion of T4 to the biologically active T3 is impaired by nutrient deficiencies, by inflammation, or by chronic illness, resulting in normal TSH and normal T4 but inadequate active T3 at the tissue level. The second is Hashimoto's thyroiditis, the autoimmune destruction of thyroid tissue that can produce fluctuating thyroid function with intermittently normal TSH in its early stages. Both of these are detectable with additional testing that goes beyond TSH. Specifically free T3, free T4, and thyroid peroxidase antibodies. The specific request for your physician if you are experiencing morning exhaustion alongside cognitive slowing, constipation, cold sensitivity, or dry skin. Ask not just for TSH, but for free T3, free T4, and thyroid peroxidase antibodies. That complete panel gives you and your physician the full picture of thyroid axis function rather than the single upstream measure that standard screening provides. If your free T3 is in the lower quartile of the normal range, despite a normal TSH, the research on T3 and cellular energy metabolism and the clinical experience of physicians who specialize in thyroid dysfunction suggests this is worth a careful clinical evaluation rather than a dismissal based on a normal TSH alone. The nutritional foundations of thyroid hormone synthesis and conversion are also worth addressing specifically because several micronutrient deficiencies that are common in adults over 60 directly impair thyroid function. Selenium is the mineral cofactor for deiodinase enzymes, the enzymes responsible for converting T4 to active T3. Selenium deficiency impairs T3 production even when the thyroid is producing adequate T4. Brazil nuts are the most concentrated dietary source of selenium. 1 to 2 Brazil nuts per day, available in bulk at Whole Foods, Sprouts, and Amazon under the Kirkland Signature Brazil Nuts label from Costco for approximately $10 to $14 per pound, provides 150 to 200 micrograms of selenium, which is within the research-supported range for maintaining deiodinase enzyme function. Do not exceed 4 Brazil nuts per day. Selenium toxicity is a real concern at chronically high doses. Iodine, zinc, and iron are additional thyroid function cofactors. If any of these are deficient, thyroid hormone synthesis is impaired at the enzymatic level independently of glandular function. The third cause is cellular energy dysfunction, specifically the mitochondrial decline that accumulates with age, and that represents one of the most significant and least publicly discussed contributors to fatigue in older adults. Mitochondria are the organelles within virtually every cell in the body responsible for producing ATP, adenosine triphosphate, the molecular currency of cellular energy. Every biological function that requires energy, muscle contraction, neural signaling, cardiac pumping, hormonal synthesis, immune activity, draws on the ATP produced by mitochondria. After 60, mitochondrial function declines through several well-documented mechanisms. Accumulation of mitochondrial DNA mutations from oxidative damage, decline in the enzymes of the mitochondrial respiratory chain, reduction in mitochondrial density per cell, and decline in the production of the mitochondrial membrane components that maintain the electrochemical gradient required for ATP synthesis. The consequence of mitochondrial dysfunction is not a dramatic or acute symptom. It is a pervasive, systemic reduction in the capacity for cellular energy production, which manifests clinically as the exact kind of chronic, nonspecific fatigue that most adults over 60 attribute to aging. The body is producing less energy per unit of effort. Everything costs more, recovery takes longer, and sleep, which itself requires significant mitochondrial energy for the active biological processes it comprises, is less restorative because the mitochondria running those restorative processes are operating at reduced capacity. The nutritional interventions most directly supported by the research on mitochondrial function in older adults are specific and nameable. Coenzyme Q10 in its ubiquinol form. CoQ10 is a critical component of the mitochondrial electron transport chain, and its endogenous production declines by 40 to 50% between ages 20 and 80. Has the most extensive evidence base of any supplement for mitochondrial support in aging. Kunal Ultra CoQ10 in the 200 mg ubiquinol formulation, available at Costco, Walmart, and Amazon for approximately $35 to $45 for a 60-count supply, provides therapeutic level dosing of the bioavailable form. A clinical trial published in Biofactors found that CoQ10 supplementation at 200 mg per day significantly improved fatigue scores, exercise performance, and subjective energy levels in adults over 60 compared to placebo over 12 weeks. Nicotinamide riboside, a precursor to NAD+, the cofactor that is directly required for mitochondrial energy metabolism and whose cellular levels decline by 40 to 50% by age 60, has emerged in the last decade as one of the most compelling research targets in mitochondrial aging. A clinical trial published in Nature Metabolism found that nicotinamide riboside supplementation at 500 mg twice daily significantly increased cellular NAD+ levels and improved mitochondrial function markers in adults over 55 compared to placebo. True Niagen by Chromadex, available on Amazon and at Costco for approximately $40 to $50 for a 30-day supply at the research-supported 300 mg dose, is the most extensively human clinical trial-studied NR product commercially available, with 11 published human clinical trials at the time of this recording. Not all NR products are equivalent. Manufacturing process and stability matter significantly for this molecule, and true Niagen's backing by the company that developed NR and whose researchers have published the foundational NAD plus aging research makes it the most clinically documented option in this category. Magnesium is the final nutritional factor I want to address in the mitochondrial context, because magnesium is a cofactor for over 300 enzymatic reactions, including the ATP-ACE enzymes, that are directly responsible for the final energy-releasing step of ATP utilization. Magnesium deficiency, which is estimated to affect 45 to 50% of the U.S. adult population, and which is compounded in adults on thiazide diuretics and proton pump inhibitors, as I described in previous videos, reduces the efficiency of ATP utilization throughout the body, producing fatigue that is metabolic rather than muscular in origin. Pure encapsulations. Magnesium. Glycinate at 240 milligrams of elemental magnesium taken at bedtime addresses both the sleep quality benefit I described in the RLS video through NMDA receptor modulation and the mitochondrial energy substrate need simultaneously. The fourth cause is iron deficiency anemia or subclinical iron deficiency. And I include this separately from the mitochondrial discussion because it operates through a distinct mechanism and because it is among the most common and most consistently missed causes of morning fatigue in women over 60 in particular. Iron is the central atom of the hemoglobin molecule in red blood cells. It is what allows hemoglobin to bind and carry oxygen from the lungs to every tissue in the body. When iron is deficient, hemoglobin production falls, red blood cell oxygen carrying capacity falls, and every tissue in the body, including the heart, the brain, and the skeletal muscle, receives less oxygen per unit of blood flow. The clinical consequence is fatigue that is particularly pronounced in the morning, when the body is transitioning from overnight fasting to the energy demands of waking, and that worsens with any physical exertion because the muscles cannot receive adequate oxygen for aerobic metabolism. The diagnostic nuance that matters, as I noted in the RLS video, the normal laboratory range for serum ferritin, the primary measure of iron stores, is set at a level that identifies frank iron deficiency anemia, but that significantly understates the range of iron sufficiency required for optimal function. A serum ferritin of 15 micrograms per liter is technically within the normal range at most laboratories. A growing body of research, including studies published in the British Journal of Hematology, suggests that fatigue persists at ferritin levels below 50 to 75 micrograms per liter even in the absence of anemia, meaning the hemoglobin is technically normal, but the iron stores are insufficient to support optimal mitochondrial function and neurotransmitter synthesis. The specific request asks for both a complete blood count, which identifies frank anemia, and a serum ferritin with the actual number, not simply a normal or abnormal interpretation, so you can assess whether your ferritin is at the functional sufficiency threshold rather than simply above the laboratory minimum. I want to tell you about a patient I will call Frances. Frances was 71 when she came to me with a chief complaint she had been making to various physicians for 3 years. I sleep fine, but I wake up exhausted every single morning. She had been told it was aging. She had been told it was depression and offered an antidepressant she had declined. She had been told to improve her sleep hygiene. She had purchased a new mattress. She had eliminated caffeine after noon. Nothing had changed. She was sleeping 7 to 8 hours most nights. She was waking unrefreshed every morning. She had adapted her life around afternoon naps that were no longer optional. When I completed a comprehensive evaluation, including a home sleep apnea test, a comprehensive thyroid panel including free T3 and TPO antibodies, a complete blood count and serum ferritin, and a detailed nutritional assessment, 4 findings emerged that her previous evaluations had not captured. Her home sleep apnea test returned an apnea-hypopnea index of 18 events per hour, moderate obstructive sleep apnea that had been entirely asymptomatic by the classic criteria, with no loud snoring reported by her husband and no witnessed apneas. Her free T3 was 2.4 picograms per milliliter. in the lower quartile of the normal range with a TSH that was normal at 2.1. Her serum ferritin was 22 micrograms per liter, technically normal by laboratory reference ranges, but below the functional sufficiency threshold supported by the fatigue research. And her dietary selenium intake, assessed through a 7-day food recall, was less than 40 micrograms per day, well below the recommended 55 micrograms per day, and at a level that the deodyinase enzyme research identifies as potentially impairing T4 to T3 conversion. We addressed all 4 findings in sequence: sleep apnea treatment with a ResMed AirSense 11 on auto-ramp, selenium supplementation through 2 Brazil nuts per day, iron optimization with Thorn iron bisglycinate to raise ferritin toward the 75 microgram target, CoQ10 at 200 milligrams daily in ubiquinol form, nicotinamide riboside at 300 milligrams daily, magnesium glycinate at bedtime. At Frances's 4-month follow-up, she told me something I hear frequently enough in these conversations to find it meaningful even after 22 years. She said she had forgotten what it felt like to wake up rested. She had been waking exhausted for so long that refreshed morning wakefulness had become something she associated with a past she could not quite access. At 4 months, she was waking refreshed most mornings. Not every morning, but most. Her afternoon naps had become optional rather than mandatory. Her serum ferritin was 68 micrograms per liter. Her sleep apnea treatment compliance was 6.4 hours per night on average. She had not been started on thyroid medication. The selenium supplementation and iron optimization had produced a sufficient improvement in her free T3 to avoid pharmacological intervention at this stage, with continued monitoring in place. Frances's case is not a medical miracle. It is what happens when the question shifts from how much did you sleep to what is the biology inside those hours, and when the answer to that question is pursued systematically rather than being attributed to aging and left in place. 4 specific, identifiable, treatable biological factors. None of them were aging. All of them were addressable. And 3 years of morning exhaustion that had been attributed to getting older resolved in the majority of mornings in 4 months. I want to close with the framing that I hope changes how you think about morning fatigue after today. The body does not wake exhausted because it aged. It wakes exhausted when specific biological processes that should have occurred during sleep did not occur adequately, because the airway was obstructing dozens of times per hour, because the thyroid was not producing or converting enough hormone to run the cellular machinery of restoration, because the mitochondria lacked the substrates they needed to produce the ATP that repair processes require, because the blood was carrying less oxygen than the tissues needed, because iron stores were below the threshold that supports optimal function. These are not mysteries, they are mechanisms, and mechanisms respond to investigation and intervention in ways that aging, treated as a categorical explanation, never can. Count the causes I have described today. Think about which of them you have never specifically been tested for. Think about the sleep study that has never been ordered, the thyroid panel that has never gone beyond TSH, the ferritin that has been reported as normal without the number, the CoQ10 and NAD+ conversation that has never happened in a clinical setting. Any one of those gaps may be the entire explanation for the exhaustion you have been waking to every morning. Any one of them is worth investigating before accepting that this is simply what 65 or 70 or 75 feels like from the inside. I want to ask you one question before you close this video. When you wake up tomorrow morning, I want you to notice, on a scale of 1 to 10, where 1 is completely exhausted and 10 is genuinely refreshed and ready, what number you give yourself before you get out of bed. Write that number in the comments today and come back and write it again after you have implemented even one thing from this video. Because that number, morning restoration quality, is one of the most meaningful and most ignored measures of health in adults over 60, and it deserves a better answer than the one most people have been given. Share this with someone who has been told their morning exhaustion is just aging, because it may not be. And the difference between those two explanations, aging and a treatable biological mechanism, is the difference between adapting around fatigue for the rest of your life and finding your way back to mornings that feel the way mornings are supposed to feel.